Good morning. So I'm Dr. Abdul Razik. I just joined here as a consultant interventional radiologist. I finished my training from AIMS in 2020, and I joined here in February this year. So today I'll be speaking on the scope of interventional radiology in obstetrics and gynecology. This talk is primarily meant for gynecologists and emergency physicians. I'll be speaking on the current indications as well as the current evidence for all the procedures that we do. So now IR or interventional radiology is a relatively new branch of clinical medicine. It has already reshaped clinical practice worldwide. And women's medicine. Today I'll be speaking on the scope of interventional radiology in obstetrics and gynecology. And this talk is primarily meant for obstetricians as well as emergency physicians. So as we all know, interventional radiology is a relatively new branch of clinical medicine. It already has reshaped clinical practice world over. And women's imaging is no exception. And interventional radiologists can collaborate with obstetricians and gynecologists to tackle several complex problems. So the advantages of IR mainly come from the fact that the access that we obtain in IR is only a few millimeters in size. So IR is minimally invasive, which results in better patient comfort, early mobilization of the patient, that results in lower risk of venous embolism. Additionally, there's shorter hospital stay and organ preservation in many cases. And overall, although the initial cost may be a little high at the end because of shorter hospital stay and lesser morbidity, the overall costs are lower in interventional radiology. Now, what all are the vascular procedures that we can perform or that are routinely done in obs and gynec related interventional radiology? So the first one is uterine artery embolization. Among this is a treatment option for fibroids. So this is a very common treatment option and has become a standard of care in patients who are symptomatic for fibroids. Second and more upcoming indication is adenomyosis of the uterus, as well as arteriovenous malformation. Uterine artery embolization also has a role in postpartum hemorrhage. Next, coming to reducing intraoperative blood loss in case of adherent placenta, IR can offer prophylactic balloon occlusive procedures. And then we can also perform in certain gynecological indications, such as pelvic venous insufficiency or pelvic venous congestion syndrome, where ovarian venous embolization can be done. What are the non-vascular procedures that we can offer? These include ablation. So HIFU or high intensity focused ultrasound can be used for fibroids and adenomyosis. Microwave ablation can be offered for uterine fibroids. In addition, fallopian tube recanalization can be offered for occlusion of these fallopian tubes. And of course comes drainage and biopsy. In this talk, I'll be primarily concentrating on the vascular procedures in obs and gynecology. So first, I'll come to the role of uterine artery embolization in fibroids. Now, this is more popularly known as uterine fibroid embolization, though it's scientifically a less accurate term. So UFE was first performed by J.J. Merland. He was an interventional neuroradiologist in France. So this was performed in 1974 when his obstetricians requested a pre-op procedure for a highly vascular fibroid. So they did gel form embolization of the uterine artery, which helped in reducing the blood loss. So this was published in a French journal in 1976. Since then, the indications for UAE in fibroids is widened. The primary indication is treatment of symptomatic fibroids. So UFE can help in reducing pain attributable to fibroids. That can be either a crampy pain, which is more during the menstrual cycle, or focal tenderness, or even a bloating sensation that can be truly attributed to fibroids. Then it can treat pressure symptoms such as constipation, hydronephrosis, even perception of a mass by the patient. Then coming to menorrhagia. So fibroids are very effective. UFE is very effective in treating menorrhagia in patients with fibroids. Less commonly, fibroid can induce infertility, and in such patients, myomectomy is the ideal treatment. Since UFE can result in a decrease in fertility, but still in patients who are not candidates for surgery, fibroids can be UFE can be performed because it's not an absolute contraindication, and in many cases, fertility is preserved even after UFE. So what are the anatomic criteria? Is there an anatomic criteria at all? Actually, there is no anatomical criteria. All types of fibroids are eligible for UFE, whether they be single or multiple, whether they are submucosal, intramural, or subserosal, and whether they are smaller giants. So all fibroids are eligible for UFE, regardless of their location, size, or number. But there are certain special scenarios. For example, giant fibroids may take vascularity from the uterine artery and also from extrauterine supply. So they may respond to a lesser extent as compared to smaller fibroids. Cervical fibroids also have collateral supply from cervicovaginal branch, which is usually not embolized in UFE. So they may not be completely treated. Traditionally, there's been a concept that pedunculated subserosal fibroids as well as intracavitary fibroids are contraindications to UFE. This was from earlier case reports which suggested a higher risk of detachment and peritoneal migration for subserosal fibroids, pedunculated subserosal fibroids, as well as higher risk of expulsion for intracavitary fibroids. But as of now, there is no evidence which contradicts UFE in these procedures, and several authors have found that UFE is a safe and effective procedure for both pedunculated subserosal fibroids as well as intracavitary fibroids. Now, what are the contraindications for UFE? So there are three absolute contraindications. One is current pregnancy. It's always important to rule out a current pregnancy in a patient who's about to undergo a UFE. Then presence of a known or suspected gynecological malignancy. So we always do preoperative MRI and rule out a gynecological malignancy, as well as presence of a current uterine or adnexal infection. So these three are the absolute contraindications for UFE. Relative contraindications are those conditions which can be managed and are not absolutely a contraindication. So these include contrast material allergy, which can be managed by changing the contrast agent, performing pre-medication with steroids. Then patients with renal failure. So if the degree of renal failure is lower, then we can prehydrate the patient, offer MS-style cysteine. So all these have been proven to reduce the risk of renal failure post angiography. Next is coagulopathy. So these three are relative contraindications. Now, how we do a UFE? So first we do an arterial access. So that is commonly performed through a femoral or radial route. A radial route is more comfortable for the patient because it enables early mobilization, but is more technically difficult as compared to a femoral route. So both internal iliac arteries are accessed bilaterally using catheters, and then the uterine artery is catheterized super selectively using a microcatheter. Subsequently, an embolic agent, which may be a particle, commonly for fibroids we use particulate agents like polyvinyl alcohol or trisacral gelatin. So these are used to embolize the uterine arteries. So these are some representative images. So this is an axial section of the uterus. So here we can see the uterine arteries from which arise the arcuate arteries and then the radial branches. So commonly in case of fibroids, you see blood supply from both sides. So in UFE, almost in all the cases, we do bilateral embolization. So this is representative images with microcatheter lodged within the distal uterine artery, and subsequently these particulate embolizing agents are released, which go distally to the bed of the uterus and then block these arteries. These are some representative images. So we can see bilateral uterine axis. So these are catheters which are placed at the bifurcation. And then accessed using microcatheters. So we can see microcatheters going right till the end of the uterine arteries. Then this is the angiography, which shows large fibroid with non-tapering and tortuous kinds of. This is the image after embolization. So they've embolized using particles. So we cannot see the uterine blood or the fibroid blood. We can see only the proximal uterine arteries.
ഷഹനാസ് എന്നൊരു കുട്ടിയുണ്ട്, റിസർച്ചിലുള്ളതാണ്. ഷബീറിന് അതേ ഡിഗ്രി PDS കഴിഞ്ഞിട്ട്. കാര്യമായ പണി ഞാൻ പറയുന്ന പണി ഇങ്ങനെ പ്രൊജക്ട് ഉണ്ടാക്കലും പറ്റില്ല. അവർക്ക്
So how is the post-procedure management after UFE? So typically the patient is advised strict bed rest for around 6 to 8 hours, depending on the size of the sheet that we've selected. And subsequently, once the patient is fine and is pain-free and is fever-free, then they can be discharged on the next day. So usually we perform follow-up at 1 month, 3 months, and 6 months. During these, a clinical examination is performed. At 3 months, a contrast-enhanced MRI is also performed to assess the degree of infarction in the fibroid and also reduction in size. So what are the common post-procedure issues? So one common issue that we face after UFE is pain. So after UFE, as I said, there are particles are sent into the tumor bed or the fibroid bed, and that results in ischemia, which results in pain. So pain is usually maximum on day 1 and then subsequently subsides over the next few days. And some patients, the pain can be excruciating. So we typically manage pain with intra-procedural as well as post-procedural analgesics. Now, we routinely provide either a non-steroidal agent or we provide narcotics like fentanyl during the procedure routinely. And thereafter, post-procedure analgesics are titrated based on the patient's symptoms. Post-embolization syndrome is another very common syndrome. It's a very common symptom after any embolization in the body. So it is not considered as a complication. It's an expected syndrome. So many patients develop transient fever, nausea, and fatigue after embolization. That is because of the release of cytokines resulting from infarction of the organ. So that typically peaks around on the second day and subsides by around a week and can be easily managed conservatively. So this is strictly not considered a complication. It's an expected outcome after uterine fibroid embolizations. Now, how are the outcomes after UFE? So there are 2 large RCTs which have compared UFE versus hysterectomy in patients who have symptomatic fibroids. So the more popular one is the EMI trial, which was conducted in Netherlands, was a multi-center RCT. It included around 177 women. The second one is a REST trial, which was conducted in the UK and included around 150 women. So EMI trial recently published their findings after 10-year follow-up post UFE, and this was published in 2016. I'll just summarize the findings of the RCTs. So between UFE and hysterectomy, the authors found that there was no significant difference in the quality of life at 10 years of follow-up. There was no significant difference in the symptoms also. So the improvement in symptoms was comparable between the two groups. And there was no significant difference in patient satisfaction. So this was measured on the basis of whether the patients would recommend UFE to a relative or friend. And the score was 90% for UFE and 87% for hysterectomy. So UFE also enables faster recovery, although it had a slightly higher rate of re-intervention as compared to surgery. So at 10-year, EMI trial found that at 10 years of follow-up, EMI trial found that 69% of patients who underwent UFE at 10 years of follow-up avoided a hysterectomy. Now, this is a very important finding because this trial was conducted back in early 2000s. So at this point of time, the technical availability that we have as of now was not available. The technical catheters and all this stuff were not available at that point of time. And all these cases were difficult and didn't require re-embolization. So considering all these limitations, 69% is a very significant number. And after this trial, American College of Obstetrics and Gynecology has accepted UFE as a primary treatment modality in symptomatic fibroids. So this is a recent RCT which has come up in New England Journal of Medicine. So this has compared uterine artery embolization versus myomectomy for uterine fibroids. So one issue with UFE that has been long running is that UFE can reduce fertility. So people have looked at comparing myomectomy versus uterine artery embolization in patients who deserve or who wish to preserve fertility. So this was a multi-center RCT in which 254 women are equally allocated into a UAE arm and as well as a myomectomy arm. So the quality of life wasn't very significantly different. The score was around 84, slightly higher for myomectomy versus 80 for uterine artery embolization. And the perioperative complications were actually lesser for uterine artery embolization at around 24% versus 29%. So what are the adverse events after uterine fibroid embolization? So this has come from a large registry of outcomes data post-UFE. This is known as the fibroid registry. So it has a follow-up of around 1,800 patients. So it has summarized that UFE is a remarkably safe procedure. So major complication rate in hospital is around less than 1%, and 30-day the major complication rate is around 5%. So they've defined major complication as the need for readmission or prolonged admission or permanent disability or death. So most common complication which has been attributed as a major complication was pain, because once the pain did not subside, many of them needed a prolonged admission or readmission. Death occurred in none of the patients. So what are the adverse events or complications that can come after UFE? So one is intra-procedural complications such as arterial injury and non-target embolization. So until you go deep into the uterine artery and selectively and carefully inject the particles, they can migrate into other arteries such as the vesical artery or the gluteal arteries and produce complications. So this can be avoided by a skilled operator. Then post-procedural, one is pain requiring readmission, persistent symptoms of fibroid that can come due to incomplete infarction of the fibroid. So this we had already discussed in giant fibroids and cervical fibroids, which may be difficult to completely necrose. So in these conditions, a patient may come up later with persistence of symptoms. Sometimes intracavitary or submucosal fibroids can become small in size and become more intracavitary with time, and gradually they get sloughed off. So in many patients, they get sloughed off. There is mild vaginal discharge and mild cramps, and that is not an issue. But in some patients, there can be arrest of passage through the cervix or infection of the detached fibroid. So in such cases, surgery may be required. So this is the most common indication for surgical intervention after UFE. So we counsel all patients with intracavitary fibroids or submucosal fibroid that this complication is a possibility. Ovarian failure with amenorrhea can result in around 8% of patients. So this occurs because there are several uterine artery to ovarian artery collaterals. And when we use particles, some of these particles may migrate into the ovarian artery, resulting in failure. But as a precautionary measure to prevent this, we use larger particles when we are doing uterine fibroid embolization. So this is not commonly seen. And if seen, this is usually seen in patients over 45 years of age. And the most serious complication is pulmonary thromboembolism. So as we all know, all these patients, even UFE induces a temporary procoagulant state. So there's a small, minuscule, but a risk of pulmonary thromboembolism in the few days following UFE. So one important issue is fertility, and there have been a lot of trials comparing the outcome of fertility outcomes after UFE. So one large trial conducted in the Czech Republic found that myomectomy had better reproductive outcomes after 2 years. So 50% of the patients that participated after UFE conceived. Also, UFE had greater risk of spontaneous abortion and placental implantation issues in the subsequent pregnancies. So if fertility is to be preserved, myomectomy is clearly a better option. But UA is still an option. So the need to preserve fertility does not preclude uterine fibroid embolization. Uterine UFE can still be considered in patients who are poor surgical candidates because of comorbidities, and in patients who have large number of fibroids which are difficult to treat with myomectomy. So in these conditions, in patients who desire to preserve fertility, UAE can still be offered. The next and more upcoming role is uterine in adenomyosis. So it's still an upcoming role, but has been widely practiced in many tertiary care centers as an alternative to patients who require hysterectomy for the past 15 years. In a systematic review, De Bruin et al. Has found that the outcome, the short-term improvement with UFE is reasonably good. So around 90% short-term improvement, around 75% long-term improvement. And the improvement in symptoms is better when there is a combination of adenomyosis and fibroid. So there's an ongoing RCT known as the Questa trial in Netherlands. It started in 2005. We're expecting the results anytime soon. So this is an example. So here we can see a microcatheter advanced distally into uterine artery. You can see tortuous arcuate arising from the uterine artery. And this is the abnormal blush of the focal adenomyosis.
Injection.
This was a pre-op and post-op imaging. You can see that this was the focal adenomyotic area in the pre-op pre-procedure imaging. It showed near complete enhancement. So in the post-procedure imaging, there was no infection in this case, but the size of the uterus as well as the junctional zone significantly reduced. So there are key technical differences when you do uterine artery embolization for fibroid embolization. One is the size of the particles used. We use smaller particles because we need to obtain distal embolization. And adenomyosis has higher rates of recurrence when compared to fibroid, but still long-term outcome is satisfactory. Next indication is uterine arteriovenous malformations. Now, arteriovenous malformations can occur after pregnancy, normal pregnancy, after miscarriage, can occur with intrauterine tumors, or after procedures. So they can produce torrential bleed, and uterine treatment modality in large AVM, in any form of surgery. The issue with surgery is that sometimes large AVMs can recruit lateral vessels. There's a high risk of bleed. In addition, UAE may preserve the uterus and even in some cases may preserve fertility. So the usual agents are, again, as I said, alcohol, similar to that we use in fibroids. In addition, we use also N-butyl cyanoacrylate, which is tissue glue, as well as onyx. So these two are liquid embolizing agents. So the target of embolization in AVM is to obliterate the nidus. So if you do not obliterate the nidus, which is a true area of abnormality, there is a high rate of recurrence, because then if the nidus is not obliterated, it can recruit vessels from other sources. And in many patients, one session may not be adequate. So in early AVM, one session may be adequate, but in more advanced cases, patients might have to be treated in several sessions. So there is no large trial for uterine AVM because it's not a very commonly reported condition. So there are anecdotal case reports as well as case series. So in one case series of 20 patients, they found that UFE had a technical success of around 90% and similar clinical success. And only a single session was needed in most of the patients. So this was one of the cases that we had performed recently. So this was a lady around 42-year-old who had come with a miscarriage and then bleeding for 3 months. So on ultrasound, there was this tortuous arterial channels along the left lateral wall of the uterus. So we did a uterine artery embolization for this patient. So here is a microcatheter which has been advanced distally into a uterine artery. And the contrast run shows tortuous arcuate arteries supplying a nidus here. So this is a nidus. So this was a right-sided run after left-sided uterine artery embolization. This showed again tortuous arcuate arteries, but no nidus was seen here. So we embolized with PBA particles followed by gel form. So first we did a left-sided embolization. Since the nidus may be obliterated partially, I also did a right-sided embolization because AVMs are known to recruit more vessels later on and then recur. And then when they recur, they may be more difficult to treat with UM. Next, a very important indication is postpartum hemorrhage. So postpartum hemorrhage is a major cause of maternal mortality, and UAE has a role in failed medical management of PPH. So it is first reported by Brown et al. The advantage is that during an angiography, we can detect a focal bleeding as low as 1 to 2 ml per minute. So this is in cases of cases where, such as a vaginal or uterine laceration or uterine rupture, where there's an active source of bleed or pseudoaneurysm. In cases of uterine atony-induced PPH, we may not see a focal area of bleeding. So typically in cases of PPH, since the issue is temporary, we only need temporary embolization. So we typically do it with gel form particles. So gel form are not permanent embolizing agents. So they are temporary and they get resolved over 3 weeks. So during that period, they provided a temporary occlusion of the uterine artery. So the advantage is that the uterus is preserved, the fertility is preserved, and it can treat the temporary situation effectively. So often gel form embolization is performed in conjunction with a balloon catheter. So many operators place a balloon catheter into the uterine artery ostium, and then through that they put in a microcatheter and embolize with the gel form. Now, if gel form is not inadequate, they can always inflate the balloon and bring a more proximal control of bleeding. So as I said, uterine atony, you may not see a source of bleeding. In such cases, we prophylactically do a gel form embolization on both sides. So the outcomes studies have shown that in PPH, uterine atony has a clinical success of around 90% and very low procedure-related morbidity. And there's a low risk of recurrence, mostly because the issue is temporary and there's preservation of fertility. And this is higher than in cases of UFE for fibroid adenomyosis because we are using temporary embolizing agents. Next, coming to adherent placenta. So here we can offer prophylactic balloon occlusion to prevent torrential bleeding during surgery. So in adherent placenta, the standard of care is cesarean hysterectomy, in which the adherent placenta is left in situ without disturbing. So UAE may avoid a hysterectomy, not uterine artery embolization. I'm sorry for the mistake. A prophylactic balloon occlusion may avoid a hysterectomy. And if at all it is needed, the procedure reduces the overall intraoperative blood loss. So there are two ways in which we do it. So first can be by the placement of an infrarenal abdominal aortic occlusion balloon. And the second is by occluding the internal iliac artery. So both these are effective modalities. But the advantage of abdominal aortic occlusion is that sometimes adherent placenta, especially when it's percreta, can recruit vessels from different arteries, such as the vesical arteries, sometimes from external iliac arteries. So sometimes internal iliac occlusion may not provide adequate arrest of hemorrhage. So in that cases, abdominal aortic occlusion is more effective. The only problem is that in abdominal aortic occlusion, we need to use a larger balloon. It needs to be inflated and deflated alternatively. We found that internal iliac occlusion itself is a very effective procedure. So a study by May et al. In 2019 showed that both procedures had comparable rate of major blood loss, rate of transmission, and uterine packing. So when it comes to bleeding, both were effective. But they noticed that abdominal aortic occlusion was superior in terms of the operative time, the balloon occlusion time, as well as the fetal radiation dose. So these are two examples from the literature. So here is a balloon catheter in the infrarenal aorta. So this is the fetus, this is the fetal spine here. And this is the markers of the balloon. Embolization. So it was first done by Edwards in 1993, and currently it has surpassed surgery as the primary treatment modality in ovarian pelvic venous insufficiency. It's refractory to medication. So first we do a preliminary confirmatory angiography in the left renal vein, where we observe reflex into the ovarian veins, the caliber of the ovarian veins, and look for the size of the parauterine vessels. Commonly, the embolizing agents used are gel form or a sclerosing agent such as STS, and then subsequently coiling is performed along the entire length of the ovarian vein to prevent later collateralization. So this procedure has a technical success rate of around 90 to 100% and a good clinical success rate. The recurrence rate is also lower. And complications are rare with this procedure, primarily because it's a venous procedure. And similar to UFE, pain and fever are commonly seen after ovarian vein embolization. That's because the sclerosant induce some amount of thrombophlebitis. In addition, rarely the sclerosant may migrate and then cause issues, such as sometimes the sclerosant may migrate into a renal vein that can result in renal vein thrombosis. Though not seen with STS, sometimes with traditional embolizing agents, hemolysis may also be observed. So this is another example from the literature. So this is a Cobra catheter which is advanced into a left renal vein, and this is the left ovarian vein. So the catheter is at the ostium of the left ovarian vein. We can see reflex of contrast into the uterine veins, which are also engorged. And subsequently, STS and gel form is injected, and then coiling is done along the entire length of the ovarian vein. On the right side, a Simmons 1 catheter is used to hook the right ovarian vein ostium, and then that's also similarly embolized. Next is IVC filters. Now, IVC filters are commonly performed by interventional radiologists in patients who have a hypocoagulable state or have low volume TBT. In pregnancy, there is a controversy regarding the use of IVC filters. I'll come to that. So, pregnancy is a hypercoagulable state, and this can persist till around 2 months following delivery. So, DVT, or deep venous thrombosis, and pulmonary thromboembolism can have high morbidity. So IVC filters are indicated in patients with deep venous thrombosis who are not candidates for anticoagulation. So if you can provide anticoagulation to them, then that is the treatment of choice. But if you cannot prevent anticoagulation, there's a high risk of pulmonary thromboembolism, then we can put an IVC filter. Pregnancy is that there is a gravid uterus and there is the risk of, so the gravid uterus can compress the filter, so it can become distorted, or the filter hooks can migrate beyond the IVC wall. So there are a lot of issues with pregnancy. So typically, as per recommendation of the Society of Interventional Radiology, a suprarenal placement is performed using on the contrary, in other indications, we typically perform an infrarenal placement of IVC filter. And since the issue of procoagulant state following pregnancy lasts only a few weeks after delivery, so it's often removed around 6 weeks postpartum once the risk is abated and the thrombus is lysed. Or alternately, if anticoagulation can be initiated. So the main issue that I had mentioned before with IVC filters in pregnancy is the risk of compression, angulation, and filter migration with infrarenal placement. Even with suprarenal placement, the retrieval rates are lower because of higher risk of penetration of the filter into the IVC wall. That happens because in pregnancy is a volume expanded state. So after pregnancy, the volume returns and the IVC collapses. So that can result in the hook penetrating the IVC wall, making it difficult for us to retrieve the filter. Concluding, IRS altered clinical care in obstetrics and gynecology significantly. It can help to tackle complex problems while preserving uterus and many a times fertility also. early ambulation and lower morbidity, improved clinical outcomes, and the overall cost of the procedure. And the scope in ONG is likely to increase over time with the availability of more and more evidence. Thank you.
We have experience in aortic occlusion.
Okay.
I did 4 patients.
Okay.
2 here and 2 from Staten.
Okay.
Then for Thursday.
Yes, ma'am. Anatomic PP.
That we did here.
Okay.
And one only is second.
Okay.
That too with less amount of blood loss.
Okay.
My question is, if we apply for a large fibroid,
Yeah.
there is sloughing.
There is sloughing.
Recently, we had a Rafiq did a case in my car.
Okay.
It's a very big one. And after 3-4 days, she came with gen infection.
Okay.
I think Jackie.
Okay.
After we മനസ്സിലായില്ല I took a they were not willing for admission when mandatory.
Okay.
Even then, kept some. Even 3 months before you went.
Yeah.
The selection of cases is small.
Yeah. The patient selection.
We used to get from that AEM.
Okay. That's
After
true.
2 years,
Recurrence issue.
case is very important.
Very good. Ma'am, depends on the vascularity of the uterus. So the cost is around 80,000, 70 to 80,000. Consumables per se are expensive. There's a micro catheter and then there's PVA particle, both of which are expensive.
You said about PPH. So if we have PPH in the labor, how can we suppose you will ship the patient to cath lab or something like that?
Yeah. So
Because
the time is an issue.
time is an issue for us because
Yeah.
she may be in hypertension. But besides maybe that,
I think, ma'am,
is it possible for us to shift or something that facility can be available?
if a shock can be controlled like or compensated and we have a time to shift to a cath lab, then the procedure can be quickly done. If you're suspecting it prior atonic PPH like multiparous lady, older lady, then we can prophylactically put in balloon catheters and even be ready for gel form embolization. Otherwise, if the patient is in a compensated shock and you feel there is time to shift to the patient, the
We
catheter.
cannot assume that.
Okay.
So when is the
Somewhere near the theater is okay.
Yeah,
Because if it's failed, we can just shift the.
Yeah.
we did it in the theater.
Yeah. But the procedure was done in the cath lab.
No.
Theater only. Okay.
And in Starker, they did it in the
Cath
catalog
lab
and
shifted.
but that didn't work perfectly. The other one worked very perfectly.
Both were adherent plus.
Okay.
Okay.
Same thing we can do with the theater.
Yes, sir.
നമ്മള് അതൊന്ന് ഓട്ടിയെന്ന് ചെയ്യും.
Okay. Sometimes it may be difficult to localize the final position of the balloon on ultrasound alone, especially when there is a gravid uterus.
Everything in the
Okay.
observed.
Okay.
Yeah.
Yeah, we can do it in Siam. Okay. Siam can be done. Any fluoroscopy available, we can do it. Okay.
We could avoid hysterectomy.
Okay.
One with didn't catalog, I had to raise.
At AIMS, we have a study running on the effectiveness of uterine and it has been concluded and is unpublished as of now. So there we are using interiliac artery occlusion. And we found
But
a good outcome. Yeah, may not be effective.
Because that much addition. And if you want to remove it, we want a perfect area.
Sure.
There,
Agreed.
without that worked well.
Okay. Okay.
Fibroid size to
No definite criteria. No cutoff criteria. അങ്ങനെയില്ല. Criteria ഇല്ല. There is no contraindication.
Malignancy.
Yeah.
Even though you say no malignancy, we usually get so many
It's
myosarcomas.
It's very difficult to predict a microscopic focus of
the big one, the current, etc.
True.
Problem.
Say something about
PPH, can you do it with the CR?
So in PPH, it will be a little difficult because in PPH, we would ideally embolize with gel form. And embolization with gel form, we'll need to get it into the uterine artery, deep into the artery. If only a balloon occlusion is needed, then we can do an internal iliac artery balloon occlusion. Won't take a lot of time. Gel form will need selective uterine artery embolization.
But if you are doing it the OT,
Yes,
you
ma'am.
can apply the serum.
use a blood plasma.
Yeah, CM can be used. Yeah, CM can be used.
You said something about tubal recanalization the first. What is it?
So when there is a fallopian tube block at the conva, so after an HSD, then we can put in a catheter and guide wire combination and then try and recanalize the fallopian tube. So that has been used. Cystoscopy also same thing.
Large fibroids hormone, time for it for symptom and conversation.
Yes, ma'am. Time and the amount of clinical success.
Embolization once in a week, 10 centimeters of
Ma'am,
fibroid.
we do it in one session. So one session is done, then we reassess the patient at around 3 months. We see the size and the amount of infarction.
That's what is when you the recurrent stage,
Yeah.
no? And the majority did it outside, but the ordinary.
Okay.
But they gave it for is later.
Okay.
If there is no change in cycle, you would again.
We look at the amount of infarction. If there is no infarction, then we know that the supply has probably not come from the uterine arteries. Then we can do a selective angiography and assess. So even in MRI, we may be able to look at, because we are doing a contrast enhanced MR, we may be able to look at what the issue is, from where the collateral supply is, and we look if it's feasible to embolize that artery.
Bilateral also is important.
Yes, ma'am. It's always bilateral. Very exceptionally, people have reported doing unilateral for fibroids. That's when they found a completely normal opposite uterine artery. But the problem is that then can recruit that uterine artery and later come back with recurrence.
Selection of case is very
Very
important.
important.
And counseling is important.
It's important. Yeah.
Always count.
Yeah.
Have this option, especially in coming years.
Yeah. True.
Off topic, can we do it for area of malformation scale?
Which
Vein of Galen malformation?
I'm not doing neuro as of now, but yeah, VOG we do offer plug embolizations, yes, with the expertise available.
We have one case actually. It's a small one. It's in the follow-up from mistake. Okay. So it's picked up accidentally. It's a preterm baby. We was not going to is for protein given with okay. We suspected vein of Galen. Then embolized and confirmed.
Okay.
It's not very hemodynamically not very significant. So as of now, it's being managed by scientific.
Okay.
Regarding adenomyosis, diffuse adenomyosis, what is the effect? You said that there's another focal.
No, ma'am. I just showed an image of focal. The study is for both focal and diffuse adenomyosis. It's effective. It's very effective. We personally have seen that it's very effective. The problem is that sometimes patient can come with recurrence. So long-term outcome, the one study, a small study, there's no large study. We have a Questa trial running.
Focal, it may work like the micro. Focal adenomyosis. Diffuse, it may recur. All right.
Thank you. Same here.
This is not ours. Copy and also I want to review my statistics.